Okay, we are live. Welcome, everybody.
Hey,
Good to see you. Hope everybody is having a nice summer weekend, as nice as could be hoped for. Glad to see you all. I am today's moderator, Becky Berman, and I'm thrilled to introduce Glenn Grossman. As we know, Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, and the CDC, along with other programs in the United States and abroad. He is currently Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. Okay, so as usual, we typically start off with Glenn giving us an update of how things are looking this week around the country and overseas. And thanks to everybody who sent in questions during the week. And if you have questions while we are chatting, you can send me a chat in the chat box and I will add your question to the queue. So Glenn, how are we doing? Has it been another good week? I remember you saying last week was a good week compared to the week prior. How is this week?
yeah, definitely. It's a lot better this week than last week, so we're going in the right direction. Let me share my screen. All right, so yeah, you can see here that the total number of cases that were diagnosed, there were around 304,000, so around 300,000 diagnosed in the last week, which is still an enormous amount. So this is not under control, but we are going in the right direction. We're still not testing nearly enough, and our best estimate is that there's over 310,000 new infections per day. So only maybe 10% of them, are being diagnosed. So we are not testing nearly enough. We still have this problem. So if new hotspots forms, we don't have it under control. The current hotspots, the advantage is that because we're aware of them, we have heavy restrictions in much of the United States now where the hotspots are going on, and that's what's driving these numbers down, the heavy restrictions, forced mask wearing, and other restrictions that are in place. When you look at the total cumulative infection rate, our best estimate across the United States, and it varies dramatically region by region and state by state, but our best estimate across the United States is between 14% and 18% of Americans have been infected with COVID-19 at this point, with the SARS-CoV-2 virus. And so you can look at the shape of the distributions. For a while, the number of tests have been going down, and we still face this problem where we haven't, we're simply not testing enough. But despite that, you can see that the daily cases are dropping at a faster rate. So we need to be testing more because we're missing so many cases. But at the same time, this phenomenon that we're seeing in terms of reduced number of diagnosed cases is not due just from a testing deficiency. It's actually a real reduction in cases, which is good news. The hospitalization rate is also falling as well. The death rate we see has a delay. One of the things that we talked about last week is that there's definitely a decrease in the infection fatality rate due to two things that are really driving this decrease that we're seeing. One is that the people being infected are a little bit younger than they were at the beginning, and so they're at lower risk. And so that's a reason why we're seeing a smaller percentage of the cases who are hospitalized actually dying. And then the other reason is that we have over the months identified these treatments that work better than we knew back in March and April. And so the new treatments, for instance, remdesivir, another antiviral, dexamethasone, which is it's a corticosteroid that impacts the immune system, prevents the cytokine storm. There's other things as well. And so between these things, they've really had a remarkable impact on reducing death. And so this goes back to when we were saying earlier, months ago, in terms of Sweden. Was Sweden right to stay open? Well, now we can say definitively that they were not right to stay open, because if they had just stayed closed and then later got more infections, then they could have prevented them this percentage of deaths, presumably. And so this is a thing, and as time goes on and more treatments are approved and potentially the vaccines become available, then the death rate will only get lower from here. So this is really good news. We are seeing tremendous progress versus the first wave. A lot of us are expecting another wave come winter, given the experience that's going on in South America. But based on our experience now that we saw over the summer, there's reason to be very optimistic that even if we have more infections, there's still going to be an excessive number of deaths, which is not good, but it won't be as bad relative. And the infections fatality rate will not be as bad as it was back in March and April. When we look across other countries, let me see if my, yep, it did. Okay, good. So let's look at, so here's another example. So here is Europe, where Europe is as a whole, and then here's where the United States is. And you see that they're very different. At the very beginning, where we didn't really know what was going on, it was a new pandemic, and so there was a lot of the fog of war type of thing going on. It's, we should have locked down sooner. It didn't, it had an impact, but you can see that this first period, this first month or two, we got hit really hard. We didn't lock down soon enough. We had no national response in the United States. But frankly, in Europe, each country in Europe chose for themselves what they wanted to do as well. They were more aggressive and more prepared because we had a national strategy plan, and the states did not have the same level of sophistication. When the decision was made by the Trump administration to make it every state for themselves, then this is what you got. There was no strategic national approach to dealing with it. In addition, it was largely driven by New York and the Northeast that were densely populated regions. And so when the more densely populated a region, the higher the reproductive value, that R value. And so then it just spreads faster. And that's one of the reasons it spread so fast relative to Europe, which in many parts had a smaller reproductive value and also closed down earlier, shut down a lot earlier. The problem was Europe, after shutting down, they really took it seriously and got it under control after that. There was no excuse. After the first wave, there was no excuse to let it go on. And you can really see the difference at this point, where the United States, this was all a management issue. Before this, it was the epidemic. There was a lot of uncertainty. There were maybe some bad choices at the beginning. But since April, this is 100% a management issue, that it was just poor governance. And you see that in the United States, this is a pure governance problem, the difference that we're seeing between the United States and Europe. All of these additional cases and the additional deaths that came from that. Let's compare the deaths. So all the additional deaths past like this point, where this was all the first wave, the deaths that were continuing, past like June, all of these additional deaths, the difference, there is no excuse for that. The number of deaths could have easily come down to European levels or lower if the United States had taken a adult approach to dealing with this epidemic in the United States. And the excess, the gap between the red and the blue, that gap is all Trump deaths. There's no other way around it. This is a failure of leadership, a failure of governance, because we see it's not a philosophical concept. We see what it looks like in other countries where they had very specific policies that we decided not to do in the United States. And their economy is doing no worse than the United States is. And in fact, many countries in Europe are doing better than the United States in many ways when you look at employment rates and that kind of stuff. So this gap, there's no excuse for it. When we look at some of these other countries, so we've looked at this previously. Whoops. Let's see. So some countries are still doing well. They tend to be a little bit on the smaller side. When you start looking at Europe, it's you do see an increase that's going on now. Some of them have moved from yellow to red. Italy is still doing pretty well relatively. China is doing extraordinarily well with their heavy-handed policies. You see some other countries doing quite well as in addition, but then you see in particular South America continues to do poorly. I keep on looking there because it's winter time there still. They're coming out of their winter, and so that's what this is when the risk increases, and so that's what we're going to be seeing. Australia got hit hard. I mean, it's winter time there too. There's an interesting study I saw in the last week in Australia looking at the humidity rate, and the correlation is extremely strong between humidity and the coronavirus. So that the more humid it is, the less the coronavirus spreads. And so as the humidity goes down, then it's easier for the coronavirus to spread across. So that's one of the reasons why in wintertime it's going to be far easier for the coronavirus to spread. Let's see. So when you compare the United States, you see that this is hard to compare country to country because there's no y-axis, and so this peak in the United States is way higher than similar peaks in other countries. So it's very difficult to compare side to side. But we can see that some of these countries, like Spain, for instance, Spain was getting it under control, and they got hit really hard. And it's so easy if you don't have sufficient testing and tracing, and people aren't wearing masks sufficiently. It's so easy to get it out of control again. All right, so let's see. This is where, so the world's, one other thing I was going to show you was this map. So when you look at confirmed cases, you can see just at a glance. So some countries like Russia is still not doing very well, but some countries, you see South America is being hit particularly hard right now. Across Africa, there's some countries that are not being hit very hard. It could be just a lack of reporting that we're getting out of some of these countries, but you see that among the various countries, some of the darkest areas are where it's currently winter. And so United States is one of the few countries in the Northern Hemisphere where in the summer we're doing poorly. And so there continues to be this worry about the winter. Yeah, and so this is where we are at a glance. Any questions so far?
I like this map. I think this is the first time you've shown, maybe you showed it to us before.
I don't know.
We've been together before on this discussion, and I'm trying to remember, but anyway, I like your graphs, and then this map really ties it all together. So thank you for showing this to us. You know, it's really interesting that just this week, NYC, New York City released its antibody test results. And is it true that, ironically, Corona, New York, could be at herd immunity? Are there any zip codes that are at herd immunity?
That is a good question. Okay, so let's break this down a little bit. All right, so first, a couple of months ago, I think, New York City released a systematic sample of antibody test results from across New York City. And we talked about that previously. And so the difference between that and this is that was a strategic sample. It was a systematic sample of like random sample for each of the areas. And so because of that, the purpose of doing a systematic sample, of a random sample, is to eliminate bias. And so that was probably more accurate in some ways this is more recent, so it's more interesting in some ways as well. But the problem with this data is that this is the result of all antibody tests that were done, not a sample. And so that means that there's two things that we need to be worried about here. One is that the people that were sickest were the ones who were most likely to get tested, or the ones who thought that they were exposed were the most likely to get tested. So for instance, if someone was staying sheltered in place for months and they barely went out at all, they might not be motivated to go and get a test because maybe they might be at risk of infection to go and get a test. And so that means the ones that were least likely to be exposed were less likely to get tested. And so that means that among the people who got tested, you'd expect that there would be a higher percentage that were positive, that it wouldn't actually represent the reality, because the sickest people and the ones who thought that they were at risk were the ones getting tested. And so that you would expect would bias it a little bit higher. The other thing that's going on is that the testing rate actually varied from place to place. So for instance, in more wealthy areas of New York City, people got tested more frequently. And in addition, some of those people had negative tests, whereas in some of the poorer places, they didn't have as much, the testing rate was lower. And so that might also bias it. And so those two things together, we really have to think about in terms of even interpreting the results. So that's the first part, interpreting the results. And so let's talk about that a little bit. You can see the screen. So to your point, Corona. So there's a zip code in New York City called Corona, and it's ironic with the coronavirus. And so the Corona zip code, over half, so 51.6% of people who got an antibody test in this zip code tested positive, which is a huge number. When you look over here, so the one on the right is the percentage. You can look visually. It's the percentage who have a positive antibody test among all those who were tested. And then, of course, in terms of interpreting it, what I just mentioned a little while ago, we need to look at the percentage of people who, the percentage of people who had antibody tests. And it looks like I hid the thing that allows us to interpret it. So now we can look at that a little bit easier. And so basically, if we use Corona as a reference point, so Corona you see is this dark one over here. Corona is roughly over here. So it hasn't been tested as much as other areas. It's around 1/4. So this is tests per 100,000. And so there were approximately 25,000, maybe a little bit more in Corona. So approximately 25% of people who lived in Corona have been tested. Whereas in some parts, far, far more have been tested as percentage. But then you look over here as a corresponding percent, and you see that they didn't actually, they were much, much lower risk of being infected. And so it turns out that that the ones who have the most tests are the least likely to be infected, whereas in some cases, the ones who have the least number of tests are the most likely to have been infected. It's unfortunate. The other thing that we have to keep in mind, and this is a real important thing when we talk about herd immunity. So herd immunity varies based on the R value, based on this reproductive rate. So if the R value is huge, let's say an R value of 5 or an R value of 10, then the herd immunity threshold goes way up. And if the R value is 1 or it's 2 or 1, then the herd immunity threshold goes way down. And one of the important things, we discussed it last week, was that there are 3 things that impact the R value, the reproductive value. Characteristics and attributes of the virus itself, characteristics of the patient that's infected, and characteristics of the society in which they live. Like, so for instance, New York City, which is densely populated, it's easier to spread. You'd have a higher R value on the subway than you would in a rural area where people just don't interact with each other quite so much. And so there's a wide variation in the R value across the United States. And there's even a wide variation in the R value within New York City itself. One of the things that we noticed is that Corona has a very large average household size. And so it was very easy for it to spread there. And so unfortunately, one of the metrics here that we're seeing, this 51.6% infected, so the only way to explain that infection rate is that the R value was higher in that area than in some other areas of the city. And so that means if the R value is higher, the herd immunity threshold is going to be higher in Corona than it will be in other parts of the city, where maybe the average household household size is smaller and whatnot. And so that means that even though Corona has got to a higher antibody level first, in some ways, it's at least if there is protective immunity, which we're still not certain about, but if there is protective immunity, then they still have a ways to go. There's hopefully going to be maybe less than some other zip codes that in terms of the risk, but if we don't know what the herd immunity threshold is by area yet. But the fact that Corona got hit so hard so fast, that's another way of saying that the R value was very high in Corona, much higher than in other places. And if the R value is that high, then after people start taking off the masks and we start opening up again, the herd immunity threshold by definition is going to go much higher than in other areas. So nowhere is out of the woods yet. We still are not near done with this thing. I think that was all I was going to say about New York City.
It's really good. Ironically, Corona Queens was the first place to get to herd immunity, but oh well, maybe on another conversation.
Yeah.
That would be such an interesting part of this story, huh?
Yep.
So, when in your opening comments, you spoke about the elderly getting hit harder in the beginning than now, and this kind of second wave or second peak that we're experiencing based on different parts of the country and behavior happening in different parts of the country. Can you talk a little bit more about nursing homes? Do we have any more information on what's happening in nursing homes?
Yes, we do. So I've been using this website. This is covidtracking.com, which has a lot of really great information. And one of the things that they've been looking at are the nursing home distributions. And or rather the percentage of COVID deaths that are occurring in long-term care facilities, so which includes nursing homes, but also other types of facilities. And you can see that there's wide variation by state. I'll try to make that a little bit bigger. And so, for instance, New Hampshire, approximately 81% of all of the deaths in New Hampshire were from these long-term care facilities, whereas in Florida, only a little bit more than a third were from long-term care facilities. Some states are missing data, and it's still unclear. There are some reporting issues in New York, so we have to take what we see with a grain of salt in some of these areas. But generally, it's really interesting, I think. I mean, looking at the variation. One of the worries early on, or not worries, one of the ideas early on was that if only we could lock down the nursing homes and long-term care facilities, that we could maybe let the virus burn through the population and it would be lower risk. The problem is locking down the nursing homes has continued to be really challenging to do because you figure all of the people who work at the nursing homes, there might be 3 shifts, 8-hour shifts during the day. So you have the physicians, the nurses, the cleaning staff, everyone involved in uptaking that, even the chefs and all the different components of the nursing home, these long-term care facilities. Each of those people who work there and leave and come back might have families, they have lives outside of work, and so it's just impossible to contain it when you have such wide universes of potential exposure. And that's one of the main reasons that we need to be aware culturally that for every outbreak of whatever disease, there's always going to be some subset of the population that's at higher risk than others. That's just by definition. Every disease has higher risk people and lower risk people. And so for this disease, it just happens that one of the aspects, one of the characteristics of the higher risk people are age. And a lot of the older people in society live in long-term care facilities. And so what I would take out of this is we're doing a poor job of really protecting those at highest risk of this virus. And so it's unfortunate. But Yeah, I'm curious when we get a little bit more data from Arizona, and we know that they got hit pretty hard as a percentage. It'll be interesting to see how this evolves over time. Some of their maps let you click in to see the change over time, and this one doesn't. I was trying to identify a change over time, but I wasn't able to with good data before we met tonight. But yeah, so at a high level, I don't have much more to talk about tonight other than that. We talked previously looking at the death rates among those age 85 and over, which is a proxy, I think, for long-term care facility, even though there's a lot of people in these long-term care facilities under the age of 85. We're looking to see if, like in New York City, for instance, which got hit hard, or New York, which got hit hard, was there was an early spike in March and April in deaths among age 85 and over. And then if the death rate went below the average in the months following it, then that would be a good indication that these people who died from COVID were near the end of their lives anyway, and maybe they just got they were killed by it just a few months earlier than they would have. Whereas if you saw a spike and it went back to the average across years, what you would typically expect, and didn't fall below, then it would be a good indication that it was not just people who are the sickest of the sick and ready to die, that it was actually the people who were not, it was way before their time because they went back to the annual average. And we saw in previous weeks, I'll see if I can find it really quickly. I don't think I'm going to, I didn't prepare ahead, but let's just see. Yeah, here it is. So it's even more pronounced now, but you can see this was looking at New York City. You can see that there was this big spike, and if it was the sickest of the sick that only had a few months to live, who got coronavirus and died, then you would have expected in the months afterwards, it would have dropped below the average. And the fact that it didn't drop below the average, that it just returned to the annual average at this point, then at this adjusting for seasonality and whatnot, shows that it wasn't the sickest of the sick. These are all people, or on average, people who died before their time. And so this is a key insight that we have from the long-term care facilities, that it didn't kill off the sickest of the sick. Instead, these were people who died before their time. All right, next question.
Okay, thanks, Glenn. Thanks for sharing some more information in that area. The good news is that many people have been responsive and wearing masks, right? Responsible and wearing masks, and our treatments have improved since the very early days, right? So certain treatments that were thought to be sort of the gold standard were then shown to be not as effective. But people are talking now about convalescent plasma as a treatment. What are your thoughts? And do you feel that that is going to be the direction that we're going to be going, at least in the short term?
Yeah, so I think there was an announcement from Trump even today that they were allowing convalescent plasma to be used as a treatment. And so there's been some work on it. I don't know if I pulled out a slide in particular. We've talked about this in previous weeks, previous months at this point. So convalescent plasma, essentially what people do, so someone who's been infected and recovered has developed all sorts of responses in their blood. And so the two main ones that we talk about are T cells and antibodies. And so for plasma, convalescent plasma, this is a treatment that's been around for many, many years, many decades. And so basically you take someone's blood who's recovered, who's developed a protective immune response, then you take out only the portion of the blood that's the plasma. So you remove the red blood cells, that kind of stuff, and put that back into the patient. And the red blood cells are the things that carry the oxygen around. So if you take out the red blood cells and put the red blood cells back, then you don't have the same type of response typically as you do when you donate whole blood. So if you were to go to the Red Cross and donate blood, they take everything out. And so because you have slightly less red blood cells as a result, you might feel lightheaded and whatnot. With plasma, they return the red blood cells. And so as a result, you don't have quite the same symptoms. You sometimes have similar symptoms at the beginning, but because you return the red blood cells, it's not as bad. But anyway, with the plasma, the fraction that's remaining, there's all sorts of stuff in there. So you screen it to make sure that the patient who donates the plasma has no HIV and hepatitis C and the basic things that we look for. And then you just take that plasma and you inject it into a sick person. Early on, it was demonstrated through a bunch of clinical trials that it was safe, because there was early on a worry that, okay, it would not be safe. Then the question, once it was sufficiently safe, was, well, is it also effective? And the effectiveness is still unclear. I didn't pay close attention to what was reported today. I don't know if it was just a political decision or if there was actually new evidence that was released today. But my perception before today was that there was a slight benefit. The benefit was stronger earlier as you got symptoms. So the earlier that you had symptoms, or even were pre-symptomatic, the more likely the convalescent plasma would be to protect it and would be helpful. The problem with convalescent plasma, pardon me, is that the way you get it is that you have to get massive amounts of donations from people who have recovered. And so that requires a lot of people who are antibody positive, who have been infected and recovered, to donate plasma. And so the more people that you treat with this, the more people you need to get to donate. And I don't know that our donation levels are where they would need to be to make this a really useful therapeutic. I think that it does have some value. I think that it's already been used in some areas. In fact, we looked last week, let me see if I can find it again. There was a study released, I think it was from Texas, looking at the benefit. Let me see, I think this was it. We talked about this last week. This was from the Houston, Houston Hospital in Houston, and one of the treatments was convalescent plasma. It was used in approximately 11% of the patients in the first surge that they had, and then it was also used in approximately 11% in the second surge that they had. So it has been used even from back in March. Convalescent plasma was used in a fairly small, fairly meaningful number of patients. I mean, 1 in 10, a little bit more than 1 in 10 is not nothing. But so we've gotten more experience from it, but it's definitely not the cure-all. It's not going to be the miracle solution. This is not going to end the pandemic. It could provide a little bit of excess value, but it adds to the arsenal that we have. The problem is we can't use this as a vaccine, for instance. Like, you couldn't use this to just donate blood plasma and that people who are at high risk just receive convalescent plasma every week for years from now. And that's just because there's not enough to go around. I mean, people who have recovered and are convalescent, they have it, but getting them the amount of donations to really give the amount of therapy that would be needed at the population level, it's just insufficient. So, it adds to the arsenal. I would say it's an incremental benefit. It's not new. I mean, you can see that it has been used for months now in many hospitals across the United States. It might be used a little bit more going forward, but it's incremental rather than a major bombshell that Trump is making it seem like.
All right, there's that up. So it can be useful, but we can't rely on it entirely, is what you're saying.
Exactly. It's good to have an arsenal where you're slowly increasing the number of drugs that are proven to be safe and effective. And that's where, as time goes on, we're getting more and more drugs in the arsenal, more and more therapies, and hopefully sometime soon the vaccines. And as the arsenal gets bigger and bigger, then we win the war against COVID, and that's how it ends.
Good point. I like the way you put it. Very much so. I know we try to steer clear of politics as much as possible, though this pandemic and politics seem to be very intertwined. The website 538 just released its list of swing states. So without picking sides in the election, can you tell us how the COVID experience may have varied across the swing states?
Yeah, I think this is a really interesting question So regardless of what anyone's political proclivity is or their interest, I think everyone in the United States who has any interest in the politics is really going to be interested in the swing states and what their COVID experience might be like. Because this election is unique in some ways that we're in the middle of an epidemic. And so the COVID experience, the epidemiology that's going on might actually influence the election. So I thought there would be a lot of interest in responding to this question in looking at the specific states that 538 identified, where each of these could go either way. The way to interpret this, I'll make this a little bit bigger, is so Pennsylvania has a 23% chance of being the tipping point one way or the other to make it go in the direction of Biden or the direction of Trump. So as Pennsylvania goes, depending on how other states go as well, Pennsylvania has almost a 1 in 4 chance of being the state that's the tipping point that decides the election. Florida, 22% chance. Wisconsin, 10% chance, and so on. So these are the key states to look at, because these are the ones that could be the pivotal states that decide the election. So I thought, okay, well, let's see what the COVID experience has been in these states, and see how that might change over time, and if that will potentially be a meaningful part of what we're looking at in this election. So let me go to the next slide. All right, so what I did is I highlighted here the key states that we saw in this graphic just now as the pivotal states. And so you see up here New Hampshire is one. You see there's a cluster up here. You see there's some over here in the south, and then Colorado, Nevada, Arizona, and then Minnesota, Wisconsin up here. And so let's dig into these a little bit more. But at a glance, one thing that we can see, I like looking at this, looking at it this way, because this is new cases per million. This is the most recent day. So this is what it looks like right now. So this is the active infection. You can see that Arizona, which was a hot spot before, has gone down a little bit. Texas and Florida have it more under control relative when you normalize it. So it's per million people. And right now, these two southern states are the real hotspots, as well as North Dakota. But so you can see what it looks like at a high level. The biggest one that we're looking at here, so it looks like Alabama, 359 per million people. Let me show you how that compares globally, because once you put anything per million people, then you can compare it across anything. You can compare it across countries, across states, and it's all normalizes it based on the population size. So let's take a look over here. Is this what I wanted? Yes, this is what I wanted. So this is confirmed cases. So now the United States as a whole has 132 cases per million. So when you look at this website, I can just flip back and forth between the two. When you look at this one, you see wide variation. You see some, like Alabama, it's 360 almost. And yet when you go at a countrywide average, you see that the average is a lot smaller. We're still not doing well at all, 132. I can click into this, and you can see that this is at our peak. Our highest point was 200. Again, this is confirmed cases, so this is diagnosed with a test. And early on, there were far less tests, and so the number of people infected appears lower, but in reality, there were not enough tests. We've definitely surpassed that amount, both in terms of the number of tests and the number of cases. But anyway, 200 is what we're looking at here. When you look at some other countries, so 200, remember, look at Peru right now. So they're in the southern hemisphere again. They're at 250. When you look at, let's see some other countries that got hit hard. Let's look at Italy. So Italy at its peak never got as high as we got. So they were at 93. Again, this is diagnosed cases, so it's still hard to interpret. It was early on what we had there. But let's look at just a couple of others, what we're looking at. Spain is getting hit hard now. Early on, they peaked at around a little higher than 160. What is that? Almost 170. They're climbing back up again. But most of these, we're not looking at much higher than 200. Let's look at Chile. They got hit a little bit hard. You can see there was a point, some of this was a backlog, but there was a point so there's summertime, which rather wintertime, which is still winter there, but you see that they got hit, and at their peak, they hit 500. And so that's crazy. So now I thought, okay, well, let's compare. So we see some of these globally, what this looked like. And we can also look at this over time. So you can see, whoops, I'm trying to drag it. Oh, it doesn't want to be dragged right now. I think it's not, I think that's what it is. All right, there it is. So let's go back to March. Let me hide this. So this is December. This is March. You see which countries. So Europe was getting hit hard, and the United States started getting hit. But then over time, different countries got it under control for a while. Europe, so this is, what is this, June? Europe was getting it more under control. It was the beginning of winter time in the southern hemisphere. Russia has been doing pretty poorly. They're not reporting it very well. Like they're doing pretty poorly right now, but they're not reporting it very well. But yet when you look over here, I'm gonna have to do this. So this is back May, June, July. So you see that United States has been consistently poor. So here's where we are now. So there's definitely been change over time. You see South Africa. So this is back April, May. So this was just the beginning of their winter time. Before winter, so March, April, when the rest of the world in the northern hemisphere was getting hit hard, South Africa was pretty much spared, even though they had travel and whatnot there. And the southern hemisphere in general, you see South America as well. But then as it became winter time in the southern hemisphere, you see more and more cases in the southern hemisphere. It's hard to interpret some of these places in Africa because there's just probably insufficient testing. There probably is some protection there just from other exposures, other parasites that might be living, other exposures, other pathogens. And so as a result, there's sometimes sort of this halo effect of different viruses. Like, so we know, we've talked about the tuberculosis virus and the tuberculosis vaccine, how there was a protective effect seen in other respiratory viruses. It could be that there's other endemic pathogens that do provide some sort of protective effect. It's because in Africa, a lot of us were not expecting that Africa would be spared to the degree that it has been, based on population density, on poverty levels, other things like that. And so there's definitely some sort of protective mechanism going on that we still don't fully understand yet. Anyway, so now we've seen these numbers. Do you have a question?
No, I'm just saying it's interesting to see over time how Australia has compared to the rest of the world. How do you explain that?
Yeah, Australia is interesting. They got it under control in a better way than we did. Like, so if you click in on Australia, you see that they had their first number of infections when much of the rest of the world did. They were able to get it under control because it was still seasonally, it was still beneficial for them. It wasn't winter yet. But then it gets harder and harder to keep it under control as it's going through their winter. And it was just hard. They started to spike, and now they're getting it back under control with more severe restrictions and stuff in the population. But yeah, so Australia, but even at its peak in terms of the number of cases, I mean, let's look at the number of tests. I'm not sure how this compares to the United States. Let me put the US in there. All right, so you can see that Australia and the United States are doing the same number of tests per day relative to the population, order of magnitude. It looks like the numbers are relatively the same in terms of the number of tests per population. And yet Australia looks very different in terms of the number of cases. So we are doing insufficient tests. they're doing enough tests that they can find most of the people that are sick, whereas ours are insufficient because there's a lot of people that are sick that we're just not finding. And so Australia has done a pretty good job of keeping it under control. But when you look per million people, you see that we hit 200 or so. What is this? This is back in July, end of July, and we were there for quite some time. Whereas Australia at their peak was at 21. So it's a very different. It's a management issue. It's governance. They were just better at governance. Anyway, let's.
Australia as an example of what perhaps we could maybe expect into the fall and the winter. Their second peak, it looks like it lasted about 2 months, right?
The big difference is, remember, they started close to zero. And if you start close to zero, then it's truly a wave. Like here, you could say this is a first wave and this is a second wave. But because they went back to zero. The problem in the United States is that we hit this peak first, then we came back down, then we had another surge before going back down to zero. When we hit like fall and winter, if we're not back down to zero, it's only going to be, that's our new floor again. So this floor was over here. We're going to have a new floor, and then winter is going to hit, and it's going to go back another surge up. So that's what the epidemiologists are fearing. It's easy to call it a wave when you see a very clearly defined wave that goes up, goes back down near zero, goes up, and then goes back down. I was trying, I didn't have time to pull out the graphic, but if you remember from Back to the Future, the second part, the sequel in the series, it was a trilogy, so Back to the Future 2, where the professor had logs, multiple colored logs, where you put one log in, and you needed the log to get to a certain heat in order to ignite the second set of logs. And then that made the train go faster. And then you needed the second set of logs to get to a certain heat in order to ignite the third set of logs. You couldn't just ignite the third set of logs on its own because there wasn't enough heat to make it get started, to ignite it. And so you had to have a series of logs that made it go hotter and hotter and hotter. And I think that's what we're seeing here, where we got the first wave, we never got it under control. Under control is down near zero. Never got it under control. Then we got a second surge, which is still kind of the first wave because we never got it down. So epidemiologists are not calling these waves, or we're sort of referring to them as surges. This is the second surge, and this is going to go down, could probably continue to go down for some time. But then the question is, okay, what point? This is our summertime here when this is all happening. In winter, the R value goes back up again based on temperature, humidity. People spend more time indoors. There's flu and colds that go on at the same time, which themselves, among people who get both, can spread it further. So for instance, if someone has a sneezing symptom that's not typical of coronavirus, but it is typical of colds, then suddenly the coronavirus can spread around much more easily further distances. And so there's the worry that epidemiologists have is that we're about to have another surge. We'll get it down to some level as we approach the fall and winter, but then it's just going to surge up again after that. And that's the worry that we're seeing. And that's why we're really wish we had another shutdown to get it back to zero. And because we chose not to, we're not setting ourselves up for success for the winter.
So what I took away from that is that clearly you paid much more attention to that movie that we probably watched together in what, like 1989? Because I don't remember that level of detail. I remember the DeLorean, but that's it. So I think I need to find a clip and find out and review what's happening with the logs in that movie, because I certainly don't remember that. But then again, you clearly paid more attention in biology class than I did too.
I think we might have seen that movie in a drive-in movie theater. Either that or on a summer vacation on Black Island, one of the two.
You know what? I think you're right. And I'm impressed that you remember that level of detail. And that's a great way to describe what's going on here. So thank you for bringing us back to 1989 or thereabouts. But anyway,
Let me go back. Yeah, let me go back to our conversation. Is that what you wanted to bring me back in? I just cut you off. I'm sorry.
No, that's okay. We have a question from the audience about antibodies, but if you have something more first to say on this, then let's do that.
Well, yeah. So before we jump into antibodies, let me just continue the thought that this question was about in terms of what the experience in the States are going to be. So now we look globally as a reference point. We saw that the United States on average was 200. Most countries were far below. We were looking at Australia as an example. They had 20. And so most were far, far below. So, I mean, we looked at a couple of examples. Europe, I mean, so here's France, Germany, here's France. France at their peak was at 70, and Germany was not too different. Let's look at Germany. So Germany similarly was almost 70. And yet when we come to the United States here, we're looking at Alabama with 359 per million. And so that's normalized. So let's dig into this a little bit more. New York at its peak, 595. Connecticut actually exceeded that, but you can see that their density, so the area under the curve wasn't nearly so high. They hit it just one day, and it could just be that they had a backlog of tests, and so they happened to have a spike. Similarly, in Massachusetts, this looks like a reporting thing, where they had the peak here, which was above, a little bit above 400, between 400 and 500, and then they started coming down, and it looks like they had a backlog of tests, and that it was sort of a artifact that their peak was 557. But I would say Connecticut, just to be fair, or rather Massachusetts, to be fair, was closer to like 425 or so. New Jersey, our peak was around 485. New York, the peak was around 595, maybe a little bit less on average, depending on that spike that day. And Connecticut, it looks like it was probably a little bit closer to 400 or so. These spikes were just sort of like a testing artifact, I think. But still, 635. You see, these are far higher numbers than what we saw in those other countries. But now let's dig in. So now these are the reference points. One of the key insights here is that after the Northeast saw these levels, we got scared. And so now when you go out in most places in the Northeast, everyone is wearing masks, people are physically distancing themselves, most people are spending their time outside, outdoors, they're not spending as much time indoors in restaurants or things like that. We're really taking it seriously. And you can see that as you go forward, that we're at the end of August now. Look at New York. New York has hardly any new cases, 34 new cases per day compared to the peak. New Jersey, 47 new cases per day. And this is normalized per 1 million for all of these. So it's apples to apples across all of these states. Massachusetts, 21. Connecticut, 0 the most recent day. So we're taking it seriously. All right, so now with this context, I showed you the global context with other countries, and I showed you the Northeast context in terms of us being hit hard and where we are now. Let's start looking at the swing states that are the ones that are going to impact the election. So we saw over here, I shrunk this a little bit, but approximately, so Pennsylvania has approximately a 1 in 4 chance of being the pivotal state that determines the election. So let's see how they did. So their peak, if you look in the lower right-hand corner, their peak was 155 per million, and they're doing quite a lot better now. Their most recent day was 62. So not too different than the Northeast, although they didn't get hit nearly as hard when the Northeast got hit. You can see it's reflected here on the left-hand side. The tests have been going up great. The daily cases at first were high and then hit the second surge, but now that's been decreasing some. The hospitalization rate has gone way down versus what it was originally, and the death rate has corresponded to that, and the death rate has been much lower than back in March, April, June. And so this is good. And so Pennsylvania probably has less of an impact in terms of COVID. So in terms, I would suspect, without knowing anything else, that maybe COVID would have less of an impact in terms of the thinking going on within Pennsylvania, just because it wasn't hit nearly as hard as the Northeast. But let's look at some of the other ones. So Florida, in contrast, so let's look again. So here was Pennsylvania. Their peak was 155 cases per million. Florida, 712 cases per million. So this is even higher than the Northeast got hit. And so this was back in late July, it looks like. Maybe sometime in August is when they were hitting that. This one peak is a little bit higher than the others. So maybe the peak lasted closer to 600 for multiple days, still enormously high. You can see that that corresponds. The daily cases have come down a lot now, and the hospitalization rate is also dropping. The death rate stayed high for a while. It's coming down now some, but for me, this perhaps the people who are on the line tonight from Florida can tell us if this has been their experience, that they feel that restrictions are more common now. They feel people are wearing masks more commonly and are really taking it seriously. Because it seems like when you get these kinds of numbers, people start to know people who in their communities who got COVID. And maybe you might be more likely to know a friend who got COVID and got hospitalized, or a friend of a friend who got hospitalized. And so as that starts to become more common, then the number of people in your social network that you might become aware of becomes more common. And then it becomes part of the conversation and could actually impact things. Let's move on to the next one is Wisconsin. So Wisconsin has a 10% chance of shifting things. So their peak was not as high as Florida. They hit 204, still pretty high when you looked at some of these other countries. So relative to other countries, so Wisconsin got hit pretty hard. Wisconsin you see their number of tests went up pretty high, and then it started dropping for some reason. They're still in their surge. I mean, the numbers are coming down a little bit, but it's hard to relate that to the tests coming down, but they're still in their surge right now. And the hospitalization is not nearly as bad as it was earlier in the year, but it's still a fairly large number of people hospitalized. The death rate, there still are people dying, although it's lower than as a percentage for some other states. But this is still an ongoing situation in Wisconsin. When we look at some of these others, some Minnesota, let's see, Minnesota was almost 10% chance of impacting. They had their peak early on at 173. They still have a lot of people. They're still near there through the summer. You can see that they had a early peak, then it went down, then it increased peak again, which they're still surging again, although the number of hospitalized patients has not gone up as much. There's a difference in looking at hospitalizations across all the states now, hospitalizations now versus months ago. And that was in addition to the death rate being higher earlier on, the length of stay in the hospitals tended to be longer too. And so as a result, when you add up all of the currently hospitals at any one point in time, there were going to be more people because the length of stay was longer. Whereas later on, so more recently in the beginning of August and more currently, if you have less length of stay, then that means that there's less people cumulatively at any one point. And so they're currently hospitalized as a result, even if you have more people, even if there were the same number of people. In fact, even if this were true, that the same number of cases that we see in April and going through June, if there were the same number of cases in August, it could be the case that there were less hospitalized at any one time because of the length of stay issue. But again, we can't really compare this. It's not really apples to apples for these time periods because the testing rate was different and we weren't diagnosing quite so many people. But this is good news when you look at the relationship between the hospitalization and the death rate. The deaths are going down, but so the question is, will this impact the election? I don't know, but you see that as a proportion relative to how it's been a similar number of people of cases diagnosed on a daily basis. It did drop a little bit in this period, but you see that it's been pretty consistent down here. When we look over here, this is Michigan. Michigan, in contrast, had a very different experience. You see that their tests have been getting better. They're good. They had an initial surge. It dropped down to a really good level. It didn't get quite to zero, but it was good. And then they had a second surge. You see that they did not have a second surge in hospitalization, and they did not have a second surge in the death rate. It's still, people are still dying, but it's not as bad as it was months ago. And so it's unclear how this will impact the election. A lot of this for each state is going to depend on their current experience. Are there heavier restrictions in the states? Are people wearing masks? If you go to election day and everyone around you is wearing a mask, it seems like that's going to be a visual reminder of the epidemic. And so when you're going to cast your vote, or if you're doing a mail-in ballot because you don't want to get exposed, then that's going to be a reminder of this ongoing epidemic. And again, this might impact the election one way or the other. I'll just do a few more, and then we can move on to the next thing. So Arizona, so you recall they got hit pretty hard. It was a smaller state relative to some others, so the absolute numbers weren't quite so high when you look at them and compare them. But when you look at the normalized rate, so when you look at the number per 1 million people, you can see that Arizona at its peak was 670. Again, extremely large. That is maybe an artifact of one day, but you see that there were multiple days that were near 600. So Arizona was one that got hit pretty hard and just currently has a lot of restrictions under it to try to get the numbers back down. So again, this could have a meaningful impact on Arizona. North Carolina, you see that the hospitalization rate just kept on going higher and higher and higher. It's starting to come down a little bit, but to have this number of people hospitalized, it means that it's way more likely that either a friend of a friend or someone you know personally has been hospitalized, because you just start getting these numbers up. When you look at the number of cases per million, their peak was around 237 in North Carolina. And it still continues to be near its peak. It hasn't come down far below that. Just a few more. Nevada. So Nevada didn't get the early surge that we saw in some other places. Then they got this later surge over the summer. They've started to come down some. Their hospitalization rate was quite high, and their death rate is still going up. Their peak was around 470 per million people, and they're still producing quite a lot. 206 cases per million people per day is still far higher than you see in many other countries at their peak. So Nevada, if it was its own country, would be doing extremely poorly right now. Let me just do a few more, just because this is probably going to have an impact on the election. We'll probably return to it for many of these states. But
excuse me for 1 second. We have three different questions from the audience, so I just wanted to give you that as we're kind of nearing.
Are they related, or should we switch? Because I can just jump through these.
They are not related, and so okay. I'm wondering if we can come back and start off our session next week with some more on how the pandemic relates to politics.
I figured I have these slides here. If anyone on the video wants to look at them, they can just pause it and look specifically at the state that they're interested in, because I've captured all the swing states here. And so, so Colorado, I haven't talked about Ohio, but I talked about Nevada. So I've captured all the swing states. Anyone who's interested can go systematically through them to see how they relate. These are smaller swing states. The Virginia, like Georgia, it's only a 1% chance of swinging the election. So I think we've covered this for now. We'll see as the issue evolves over the coming months toward the election, how COVID evolves in this area, not mutates. I mean, in terms of the epidemic, how it evolves. We'll come back to it, and it's interesting. I think everyone, regardless of what their political persuasion is, I think that everyone has an interest in looking at this. So there you go.
Very, very interesting. Thank you for compiling that data for us. Okay, so as we are nearing the end of our time together, we have 3 questions. First, we have Debbie, who has a question about antibodies. Then Sandy has a follow-up question about humidity that we discussed. And then we will wrap up the evening with Marla's question. So, Debbie, I will unmute you. Okay, asking to unmute. All right, Deb, we can hear you.
Hold on 1 sec. All right, sorry. I was just curious regarding the antibodies. Are the people, if they're saying antibodies aren't lasting as long as people had hoped for, are there people who are able to get COVID a second time? Is that likely? Are we seeing that? I'm asking specifically for somebody I know who had it and is now getting tested to see if she still has the antibodies because they're not sure also. So how do we look at this?
Yeah, so there's two major responses. First, we don't know exactly what antibodies are telling us. And so we don't know if antibodies confer protective immunity. And so that's the first thing. And so, but I should say, we do believe that they do confer protective immunity. It just hasn't been proven yet. And because you can generate an antibody response, like, so for instance, HIV, people who are infected with HIV generate antibodies, but they're not protective. And so someone could have HIV, or so people, almost all people who get HIV will get HIV and have it for the rest of their lives. And though they require treatment for the rest of their lives, it hides in the body and it infects different parts of the body. And so just because they have an antibody to it doesn't mean they've completely gotten rid of it. They've completely cleared it. One thing that we know with SARS-CoV-2 is that the viral tests that we're doing, these polymerase chain reaction tests or the antigen tests that we're doing, are we're taking nasal swabs and testing the saliva. But that's only testing virus shedding in the nasal cavity or in the oral cavity. If you're having replication of the virus in your heart, we're not doing swabs of the heart. So we don't know if there's ongoing viral replication there. So the antibodies or that's different than the viral test that I just jumped to, but it's unclear exactly if there's ongoing replication inside the body. Just because we have antibodies doesn't mean we've actually truly cleared the virus inside the body, and we don't know if it's truly protective or not. So this is an ongoing issue. Like it could be the case that for some people there's a chronic form of COVID-19, and we just don't know yet. We do know that that when we've looked at people who have died, we've definitely found a lot of inflammation. We've talked about this previously. I can refer to the slide, maybe not tonight, but next week if we want to revisit this a little bit, that there's active replication of the virus in heart tissue. And that's why we know that it's an increased risk of heart attack. There's also active replication in the cardiovascular system. And that's why we know there's more clotting and stuff that's going on. There's active replication in the gastrointestinal system. And it can be found in feces over a month after you can no longer detect the virus shedding in the nose or in the mouth. So we know it's there. And I mean, we're in the middle of an epidemic, so we're not focusing on that. We're focusing on the other things, trying to get it under control. But we know a lot of people who are infected have symptoms for many months, and there's continuing to be viral replication in many of these people. It's just not identified in the nose. The reason that the nasal swab and the oral swab and saliva is so important is because that's the primary route of spreading it to other people. And so that's why we're testing everyone, to prevent the spread. But for an individual patient, just because someone's negative, has a negative test result, doesn't mean there's not ongoing viral replication inside their body. And so in terms of the antibody test, going back to the question here, so the first thing is we don't know if it's immunoprotective. The second thing is the good news. And here's the good news, is that we expect that antibodies do go down below a threshold that you can detect them. But that's not a bad thing, because then if we're re-exposed, the body retains this memory of it. And if we're re-exposed, it's not that the antibody goes down to zero, the antibody goes down to a minimum level that we can't detect at the threshold that the tests are detecting. And so then, and this is the same for almost all viruses, so this is not worrisome. But then if we're re-exposed, then we expect in most of these people that there will be another antibody generation that's created from this memory, the B cell memory. And so it would come back out. And there's also other pathways. There's T cells. If you recall, the antibodies attack the virus itself, whereas the T cells infect the cells that are replicating the virus and take the whole cell out of commission. And so T cells, we don't have a good standard test, an easy test, a cheap test to do at the population level for T cells. But for clinical studies and for investigations, we can look at T cells. It's much more expensive, but we can investigate those. And we found that the T cell response lasts very long in the majority of patients who have COVID-19. So even if there's not an antibody response that's identified, the T cells could still be reactive and still be having an effect. But again, we don't know how strong that effective, how immunoprotective it is. Is it something that's more like HIV or something that's more like a flu virus that you clear and it's completely gone? We believe it's more like the flu that you clear, but again, there's ongoing replication and we just don't have a strong answer here yet in terms of what that looks like long term.
Can I ask part two?
Of course.
So then part two would be, people would think it's safe to assume that you're safe if you've had corona and you have cleared the virus and have antibodies. But if we're unsure if people are getting it again, can get it again, are those people still possible to be carrying it? I don't know if I'm asking it the right way. Are they safe to be around?
Well, so that's the key thing. So safe to be around is a spreading issue. And if you have a nasal swab and saliva test and it's negative, and it's a true negative, not a false negative, but it's really, there's no viral shedding, then they're not contagious. The only other way that they could be contagious is if there is through the gastrointestinal route, if there's feces. And sometimes if the hygiene isn't perfect, then that might be an exposure risk that you might want to worry about. But based on the studies that we've seen, the level of contamination through that route seems like it would be very, very low versus the respiratory route that we've been looking at, the saliva and through the nasal cavity. And so it's not really a risk, there could be a very, very small risk, but at a population level, we're really not thinking about it as a true real risk at the population level if someone's negative in their nose and their mouth.
Glenn, if you come across any other additional resources or information on this week, I know still so much is unfolding and there's still so much that we don't know. It sounds like that would be great and appreciated if you shared that. Great questions, Abby. So we're going to move on to Sandy, who had a question about humidity and in particular humidity in Florida.
Well, my question, as I'm sitting here, I'm thinking it's going back and forth and back and forth. The humidity is about almost 90% here now. And I don't know if that's showing that it's keeping the spread down a little bit. I don't know if your screens are showing that. But I'm thinking in the winter, forget schools opening, that's a whole different issue. But in the winter, when people are more out than they are in the summer, and you're saying conversely that in the winter when it's cold and people are indoors, it spreads more, maybe it would help flatten our curve here because people will be outdoors in the fresh air and whatever. But then I'm saying to myself, movies theaters are about to open up. And
are they? Wow.
It's Florida, remember, and things happen here that don't happen in normal places. But so not all movie theaters, but I think some, and it's the beginning. And I know our governor is speaking about the unforeseen consequences of what's happening with suicides and trying to get things back to normal. And people back to school and work to protect these poor people and children and battered women. And so, I mean, there are two sides to this story. So my question is really not a question. It's like, I don't think there's a real solution to any of this until it's done. And what you're saying and others experts are saying, it might never be done. It might just be treatable.
No, I mean, I think I mean that might be the case. It could recur and be a seasonal thing that we see, depending on how long the protective immunity is. But I mean, we see that. I mean, it seems. You know what? I don't know if your experience was like mine, but March and April each seemed like they were 5 months long, and then May and June came, and they started getting faster. Then July came, and it seemed like it was 2 weeks long, and then August came, and it seemed like it was 1 week long. And and so I think that normally we get arsenal of drugs and vaccines and stuff that we see for different diseases. So much has been invested, not just in terms of financially, but people's emotions and their resources So many scientists around the world have shifted from whatever their primary area of research was to SARS-CoV-2 and to COVID-19. And so because there are so many brilliant minds working on it and so much money being invested, everyone has full confidence that we're going to be increasing our arsenal of treatments, and also that there will be some vaccines that become available at some point. And so as a result, I mean, we have high confidence that it's not like, oh, this is the new normal. It's not going to be the new normal. We'll get back to not having to wear masks again. It's going to take some time. We don't know exactly how long it's going to be, but it will get back to that. So yeah. Oh, but going back to your observation. So yes, so we do know the two things that you mentioned, humidity and being outdoors. Being outdoors definitely lowers the R value. If people are indoors, then they're more likely to come into contact with each other and to spread it. If they're outdoors, it's much easier to avoid spreading it. The other thing is the humidity level. If humidity is higher, then SARS-CoV-2 is harder to spread. I don't know if it's the humidity just captures it or what, but it's harder to spread. When the humidity level drops, like in wintertime, then it's much easier to spread. And so that's just something else. So in Florida, you're right, it's interesting that it's converse to what we have in the Northeast, that it's sort of, Florida's in the south of the United States, when it's winter, that's when people do go outside. So I don't know.
Thank you, Glenn. This is very interesting, all of it. Thanks.
Thank you.
And thank you, Sandy and Glenn. Thanks for your response. And we will wrap up the evening with Marla. We'll unmute you or ask you to unmute. And your question, please.
Okay, so my question is, with respect to getting into the fall and like an increased wave and with the flu and cold season, because in New York and New Jersey our R value is very low, are we in a better position for this going into this period of time versus other parts of the country where their R values are higher?
Absolutely, without a doubt. So when you start at a lower number, in fact, I like to go to this website, Test and Trace. So we are in great shape. So for instance, right now in New York, there are 15 to 16 contact tracers for every single positive test. That's an army of people. In New Jersey.
We can't, are you attempting to share your screen?
Oh, I'm not sharing my screen, so you can't see what I'm looking at.
No,
All right. All right, let me go back and say what I just said. So here's, you can see at a high level that some states are way better prepared for for the winter, for fall and winter, than others. So in New York, there is an army of 15 to 16 contact tracers per positive test. And so they can jump on a positive test, find out all the people who may have been in contact with that person, both who they might have been exposed from and who they might have given it to. They don't have to be 100% effective. Even if they're only 70% effective, then they can still, that's enough to keep the R value down so that it doesn't spread. New Jersey, you see we're at five contact tracers per. It's on the low side, but it's still enough to keep it under control. The Northeast is doing pretty well, and so we are we are doing well. So that if it starts to get worse in the coming seasons, hopefully there will be some more people who are hired, and I think a lot of people are still expecting that there will be a second surge in the Northeast because it's just going to be really hard to avoid. We'll see. I mean, it's a governance issue at this point. We know that it's going to be coming. We need to balance the economic access versus the coronavirus. Right now, it's under control, and I think that because of the revealed governance effectiveness over the last few months in the Northeast, I think that we can trust, hopefully, that they have our backs. In much of the rest of the country, it is not under control. Something like the contact tracers, that's an investment. If they just simply prioritized investing in more testing and more contact tracing, they could very quickly get it under control. Because there are so many cases, it's just exorbitantly expensive to do that much contact tracing for all the testing. And so once it's so high, it's hard to get down. But if there was federal involvement in the budget to get additional contact tracers and additional testing to a level that we have in the Northeast, then it too could be put under control. One of the biggest issues is the amount of travel across all the different states. And that's a lot of the new cases coming in New Jersey, New York, are from people in other states that are traveling in. And it's, we in the states, you're supposed to have a quarantine where if you come into the state from outside the state, from any of these other states, you're supposed to self-quarantine for 14 days, but it's hard to enforce that. Who knows if that's actually happening? I would say yes, we're setting ourselves up for success in the coming months, but as the R value goes back to a higher level and all the conditions aid the spread of the virus, it's going to be harder and harder to keep the virus at bay.
Excellent. Marla, thank you for that terrific question. Sandy, Debbie, thank you for your questions. Thank you everybody who has sent in questions during the week. Keep them coming. We hope to answer everybody's questions, and I know Glenn really works hard to make these sessions as informative as possible. So we thank you for all the work that you've put in to tonight and always. And we look forward to seeing you same time, same place next week.
Thank you, Becky, and thanks everyone on the call. It's always a pleasure.
Absolutely.
Think of some more. All your questions are great. Think of some new good ones for next week, and I'll work on answering them over the course of the week. Thanks, everyone.
Safe, be well. Take care.
Bye bye.